Welcome to another episode of NBM Talks, a series of the Narrative-Based Medicine Lab, where we speak with individuals who are working at the intersection of literature, medicine, and health. Our guests are writers, clinicians, scholars, artists, and advocates who are pushing the boundaries of what's possible in the field. Together we discuss how we can engage with narrative-based medicine principles and practices in creative and diverse ways. We hope you enjoy this episode.
Welcome back to our NBM Talks podcast. Today we have a guest, Dr. Petal Abdool, who is a geriatric psychiatrist at CAMH, the Center for Addiction and Mental Health, and a consultation liaison geriatric psychiatrist at Providence Healthcare, Unity Health Toronto. She's Assistant Program Director for International Medical Graduates and an associate professor at the University of Toronto in the Department of Psychiatry. She is the inaugural medical director of the CAMH Simulation Center and the faculty lead Simulation Education Integration for Temerty Faculty of Medicine. Her area of research is focused on the use of simulation in medical education, and Petal has led innovative technology-enabled educational interventions such as the use of virtual reality trainings to manage opioid overdose and teach clinicians on how to conduct a suicide risk assessment. I'm your host, Dr. Sarah Kim, the Medical Education Health Humanities Theme Lead for Temerty Faculty of Medicine, University of Toronto. So welcome, Petal. It's great to have you here.
It's great to be here, Sarah.
So I thought it would be really great for our listeners to hear a bit more about your role as the theme lead in simulation education and integration.
Sure. It's such a privilege to be the faculty lead and to be able to network with so many brilliant minds who are passionate about education in general and more specifically simulation. My focus in my first term in that role has been how we can further integrate simulation and competency-based medical education across our programs. Particularly, I've been focused on entrustable professional activities, or what we call EPAs, because this was one area that people were struggling with in terms, both learners and faculty, in terms of getting them done. I think one of the most exciting aspects of the work was being able to foster that interdisciplinary collaboration, and I'll give you a few examples. I was able to bring together psychiatry and surgery. Dr. Mark Wheatcroft is the Surgical Foundation's program director, and so we jointly explored some of the communication challenges that they faced in terms of getting EPAs for high-stakes assessments, like consent, for instance, for surgical procedures. So that's one area I was able to venture down. And then, Dr. Mark Rappaport, who is our faculty lead for internal review. He's also the program director for geriatric psychiatry. So he and I have been collaborating on a wonderful, innovative initiative that I know it's going to excite you. It's using Shakespeare's King Lear. So we brought in real actors and actresses, and they portray excerpts from Lear. And then our psychiatry residents observe them, and then we debrief after, and then we study how they formulate before and then after to see if that exposure to theater, to that live in situ exposure to acting out that play impacts their understanding of human nature. Mm-hmm. And particularly, of course, we're focused on the aging process and how King Lear was interacting with his family members and so on. So those are two exciting examples. And I think that this cross-disciplinary work has been deeply enriched by incorporating lived experience advisors. So we do have people with lived experience informing our design of this work and all the way to the end where we actually implement it. And so a key part of my mission in that role was to break down silos, not just between specialties, but between educators, clinicians, patients, and to create a rich community of practice that harnesses all our expertise.
Oh, that's beautiful. It's really wonderful to hear you using applied theater and theater as simulation in your work, and hearing also how you've been integrating the perspectives and the narratives of the patients and the patient perspectives in the actual curriculum design. I'm wondering what led you to this path of wanting to venture more into simulation in medical education and just the places that you derived inspiration?
It's a good question. I think I derived my inspiration from my mentors, the people that I have been taught by. People like Dr. Ivan Silver come to mind. My chief of my hospital has been very supportive, Dr. Sanjeev Sokalingam. The minute I came on staff at my hospital, we got involved in not just teaching, but in thinking about ways to enhance our teaching and deepen the learning that we expose our residents to. So I had been involved very early on working with Dr. Latika Nirula. We had applied for a small grant, a medical humanities grant, to purchase an aging suit. And we used that to help build empathy towards geriatric patients with severe persistent mental illness. And so I think that's when my passion for simulation was ignited. And fast forward to today, I get to continue that work and build on it. So it's a great thing.
That's such a great story. I can see that you've had a little bit of a theater bug in you almost in wanting to and using the geriatric suit. I didn't even know that existed. I'm curious actually for you to explain that a little bit more to our listeners of what that actually is.
So it's a fascinating thing that was developed. I first learned about it when I went to an IMSH, so it's International Meeting for Simulation and Healthcare Conference back in 2014, I think it was. So this aging suit, or they call it the PAUL suit, Premature Aging Unisex Leisure Suit. So it has weights on your joints, I guess, to simulate the experience that older people have with, joint pain and arthritis and so on. And the suit, you wear goggles that change your vision. You wear earplugs that can diminish your hearing. And in that study that we had conducted, we asked the participants to also wear headphones that simulate auditory hallucinations. And then they had to meet with a pharmacist and discuss loading their blister pack, all the while having to deal with all these physical and mental challenges. And so that suit cost around $2,000 back then. Mm-hmm. So it was not a cheap purchase, but it certainly had impact in terms of what we were able to do with it.
Wow, that's really, it almost goes beyond virtual reality, and it's more of an embodied reality that you place the learners in. And what an interesting and immersive exposure. It also makes me realize that there is a whole other thing about simulation I hadn't thought about. I know that for myself, I was thinking more of the digital world, but I didn't realize there were some tactile interventions that you've already generated research on. I'm wanting to actually just to shift a bit, because in a previous conversation, you had mentioned the influence of a documentary that you watched recently, and I wanted to give you an opportunity to speak about that to our listeners.
Well, you're revealing my passion for oldies but goldies. So this was a song that I really liked by the Beatles called All the Lonely People. So when I saw this documentary entitled All the Lonely People, I thought, this might be for me. And it's interesting because it's a documentary about social isolation, especially in the elderly, but it covered individuals across the lifespan, across the age spectrum. And it had a profound impact on me because, one, it resonated with my work in geriatric psychiatry, and it challenged some of my assumptions about loneliness, reminded me about the importance of connection and dignity, and how central that is to mental health, especially as we age. And I think about, in the documentary, they talked about loneliness having the same health impacts and risks as obesity and smoking. And I thought the stories were raw, honest, and beautifully told. And it prompted me to think more deeply about how we design clinical encounters and the educational experiences that we can offer that truly prioritize the human experience and that human connection.
I'm hearing a lot of the inspirations that you've been gathering across different ways of applied arts and theater in particular. But I'm also hearing here that in everyday kind of exposures, in this instance to film, how those have helped to challenge assumptions and challenge your perspectives and grow perspectives. And I'm wondering if you can comment on how this has influenced your work as an educator and what you choose to role model, for example, to the learners, and how you also see this being shaping a different kind of curriculum, or a curriculum that sounds actually that fits under more of the transformative paradigm of learning and education.
It's a very profound question. I think the health humanities have absolutely shaped how I understand the stories my patients bring to me, especially in geriatrics, where things like memory and narrative and identity are often so deeply interwoven. I think art really invites us to sit with ambiguity and uncertainty and to interpret and to notice what might otherwise go unseen. And I think in my clinical work, it helps me to remain open to multiple meanings, especially when you have patients that are navigating, cognitive changes or losses that are not easily captured with clinical language. And so I think the humanities remind me of the importance of empathy, that it's a skill that requires ongoing practice, and that it's a powerful tool for cultivating presence, curiosity, and reflection, not just in me, but in our learners. So I think that if I can model that and that I show that I'm always working on improving that the learners too could take heed and perhaps incorporate that into their identity as well.
Mm-hmm. And what have you observed in terms of the responsiveness from learners and from other colleagues who have had exposure to your work and participated in some of the simulations that you have designed?
The response has always been positive. I think, like you commented about the aging suit, a lot of them didn't realize just how powerful a tool simulation can be, and how it can actually put you in another person's shoes, enhance empathy, and just broaden your horizons when it comes to thinking about how patients experience the world. So I would say the learners were really excited when we had the theater production for King Lear, and we brought in, real stage actors. The comments that they wrote at the end when we surveyed them were things like, "This was one of the most amazing learning experiences in my whole residency." And you could see the change in the way that they wrote about the cases that we gave them pre and post that exposure. And the same goes for faculty. I think they appreciate the opportunity to sit still and to really do something that's so, abstract with learners, and help them to see that the work we do is very similar to this, right? And that we have to sit with that uncertainty sometimes. And it really links to wellness, right? When we're able to cope with that kind of stress and metabolize it in a different way.
I hear you speaking to some of the intangible value that these methods of teaching can bring. And it also captures many of the CAMH's core competencies that we often want to have, well, not even often, that we strive to cultivate in our learners and grasp around themes of their professionalism, their advocacy, their health advocacy, and more from the perspective, a more humanistic type of perspective around what it means to do scholarly work. You've given some wonderful examples of that as well. I'm wondering if you have some closing thoughts around your own work and the impact that and inspirations that you've drawn from the arts and the humanities in the development of simulation in medical education and integration of it as a learning tool?
So I think the health humanities, for me, I see it as a counterbalance to the technical. It's an opportunity for us to rehumanize medicine. And, we can deepen our emotional intelligence, foster ethical reflection, and really build that competence in the narrative aspect of medicine. I really reflect every time I work with patients to think about, did I truly hear them? Did I really respond to the story that I've just been told in a way that makes that other person feel seen? And I think that in a system that often privileges efficiency, for me, it encourages me to slow down and to dwell in an uncertainty and to ask better questions. And I think that the humanities are critical to supporting wellness and meaning-making for all healthcare providers, regardless of your discipline, especially in the ones that are in those fields that are really emotionally demanding, like palliative care, geriatrics, psychiatry. So I think those are some of my parting reflections. Mm-hmm. And I really appreciate the time you spent with me today.
I do have a question around what you might see in terms of the potential of the simulations that you offer in addressing topics like ageism, which is an alignment, as we try to challenge some of these biases and negative stereotypes as a faculty. I always feel like the narratives around, or ageist narratives, are things that continue to be quite dominant. And wanting to hear you speak a bit more to that as what you've maybe noticed in your work as you've created these simulations, in particular with your experiences with the suit.
So with the suit and the learners that we exposed to it, the qualitative comments that we got back were things like, I had no idea what my patient was dealing with when we asked them to do a task, or when we asked them to fill a form and they take a long time and it slows down the appointment. And so, interestingly, one major theme that came out of that particular study was that the learners said that they would be more patient and they would slow down and check in more to make sure that they were keeping pace with the patient's needs and what they were struggling with at the time. So I think that in and of itself, even though it's one theme, it's a quite powerful one, and it could make a huge difference to the patients that we see. And it definitely is a step in the right direction when it comes to battling ageism.
Mm-hmm. And it does also, I hear it addressing our own issues with communication, that perhaps it's not that the patient is not understanding, it's more that we are not meeting them where they are with information that is comprehensible to them, or in a manner that is allowing them to take it in at where they are able to process the information. So it also is making me reflect on my own perspectives and narratives around what a clinical encounter and the shape of it, what shape of it often takes.
Mm-hmm. So true.
Right. So thank you very much, Petal, for taking this time with us. And again, to our listeners, this is Dr. Petal Abdool, who you've heard from today, who is a geriatric psychiatrist at the Center for Addiction and Mental Health, and is also the faculty lead for simulation education integration for the Temerty Faculty of Medicine at the University of Toronto.
Thank you.
Thanks for listening. If you enjoyed this conversation, check out many other episodes. And if you're interested in learning more about narrative-based medicine, visit us online at narrativebasedmedicine.ca for more great content and to explore our upcoming offerings.